Okay. Thank you for this opportunity. I'm not very sure what was the exact focus of this term, requirements for achieving universal health care in India, except because there are been very different and alternative approaches that we were seeing being proposed. But I thought of looking at a system of what is the current discourse about. How has this discourse changed, and what is the discourse in this particular segment of the larger debate on universal health care? That is the requirements of universal health care, requirements of human resources for health in that. One sort of starting point that everybody uses as a reference is this particular figure of 25 per 10,000. Based upon the inter-country study, there's a norm that has been looked at as a baseline, and this is looking at doctors, nurses and midwives alone. So we're looking at this figure back as a reference point, 25 per 10,000, and where are we in this? Now, one part of the problem that is rather well known is the problem of counting doctors and nurses in India. There were at one count 700,000 doctors, which would have been exactly the amount of doctors we require, but for the fact that this is known to be a generous overcount of this. But even if you look at the World Health Organization figures, they use 19 per 10,000, of which 6 is doctors, which is, to my mind, not a bad figure at all, except that again there is a assessment that this could be a considerable overcount on this. The 12th plan raises it suddenly to uses a baseline reference of 45 per 10,000, including somewhere pharmacists and AYUSH, but not actually telling the breakup of that, continuing to discuss the topic as if it is doctors and nurses, but set for a much higher baseline of 45. And that becomes one of the points of interest, because at some point the actual process, if you were there in the early 90s or 80s even, we would be talking about, are we having too many medical colleges then? But today we are talking of huge numbers. Now, one more word on the numbers. This was a part of a poster presentation yesterday also. There seems to be a number of estimates going, and I am going to refer to these estimates when we are looking at this again. So it ranges from 2.6, Sudhir Anand and Fenn's estimates, to Krishna Rao right there on the podium, 3.8 per 10,000, which I personally use, not because he's there on the table next to me as the more robust of the various estimates that are made, to a recent PHFI extrapolative estimation where they have used 5.1 for the HLEG report, and another standard figure, which is the WHO figure I call the 6.2 per 10,000 has been used. These mean there are large implications, changes almost doubling in the amount of gaps that are calculated. And it's important to see whether it's an issue. This is just to say that I'm using doctors as a trace example, but this similar problem can be stated for all other categories of workers. It's just that it is more studied and we know more about it, so I'm using this as a reference issue on that. But here's the first point I would make about it. Is numbers so critical? Just look at Thailand, Sri Lanka and compare to India. Even with a more rational estimate of 3.8, we would be very close to what Thailand has as its doctor ratio, though Thailand has about 3 times the number of nurses to doctors. It's the nurse ratio that is really critical. We look at Sri Lanka also. But again, if we look at, suppose the same error sources are there, we will still say that yes, we would have to about double the number of nurses or actually have a greater number of doctors, but how much greater? So if we look at one way of estimating it and say, okay, 7 lakh doctors at 6 doctors and 18 nurses per 10,000 population, this is the sort of numbers of doctors you need floating around. and you look at the gaps as calculated from what exists to what is required, and you would have a gap ranging from 1 to 4.4 per thousand on the, per 10,000 on this. And then a current provision, the current output of the medical colleges is about 35,000 per year. Allow for some national, for a usual attrition, taking a career span of a doctor of 35 to 40 years. And then you say replacement even at its peak levels would be 20,000, but say about an average of 10,000. And therefore, the figures they work out to in some ways HLEG report, and in this I'm sort of using these figures as indicative, not really looking at the final validity of the calculations. So the 12th plan chapter comes up with this additional medical college requirement, additional mind you, over and above the existing 300, of 257 medical colleges, and Public Health Foundation of India, which had made its thing, recommended, the HLEG report recommended an additional 180 medical colleges. And this is the sort of figure that we are really looking at. And even this 180 would be the same as 257 if you count at 150, but if you look at the different gap estimation, it could be made at 100. So anywhere the estimations have suddenly bloated up, and we are saying we need 180 and 257. Now, being me, I become extremely cautious. I become, say, what's happening? Where's this sudden numbers coming from? Why this sudden, what is the context in which we are suddenly talking about 300, 180 more, 250 more, and instead of being more cautious on every element of budget, whereas the Planning Commission instinct is to cut down on this, it liberally goes beyond the HLEG recommendation to 257. My instincts get very, very cautious. And I look at this particular thing. And at a 25,000 additions per year, it would take 4 years to look at the gap, and 12 years even if we look at the Rao-Burman estimates of this. But at 60,000 per year, it would be, yes, 5.3 years. And no, they haven't missed it. They actually say that if you increase it like this in the 11th plan, by 2018, we would be there. And that would be the gap that is required. So actually they are quite serious in making the proposal that we should be filling the gap at 60,000 per year. But what is not very clear is whether they have looking at doctors or all MBBS doctors, or whether they are adding into the calculation the 3-year graduates and the Ayush doctors that needs to be put in. In some sense, the 12th plan document is adding that over and above the 180, whereas these are not. And at some point, the ministry's very cautious response was that we would commit to adding 10,000 additional MBBS seats during the plan period, with 30 new medical colleges and enhanced strength in the existing 300 medical colleges to reach 30,000. To most of our minds, it was a doable, achievable target with a degree of quality and well dispersed across those areas that need most. It would actually, along with the 3-year course and Ayush, have been able to fill the gap. So there is some reason to look at how this 180 and 257 is proposed, particularly because the budget line does not really provide for it. So the budget line says that this will come out of the NRHM incentive pool if and when all the conditionalities have been met, then the funds can be used for these additional medical colleges, which to say the least regarding the overall nature of reforms required is not likely to happen on this. Now, I just want to reflect a bit on what is happening in the background scenario and not make that same trend that the HLEG said of completely ignoring actually what has been happening on the ground as a basis. The last 7 years have been, there's been a big change from the earlier situation with a huge increase in the number of medical colleges, the total number of seats, and especially in nursing colleges. In nursing colleges, it's a break. Now, the rate of growth has been higher in the non-high focus states, but for the first time, high focus states have also been showing a considerable growth, and with a considerable number of relaxation, this has been possible due to an active intervention and state policy, but still the larger question as to what part of it should be public driven and private driven remains. Now, when it is privately determined or privately driven medical education, what happens is that this growth is extremely uneven and tends to grow in some states, in some categories at high cost and meant for largely external markets or for private markets which can afford to pay this. And it doesn't really contribute to the whole of the needs of the public system. And therefore, when the 12th plan says that the government should take the lead role in and private medical colleges should be allowed, at some point a case is built for now a shift from private medical colleges, which are now becoming increasingly difficult to operate in a remunerative basis. There is no returns left. If you listen to Devi Shetty's last presentations, he bemoans the fact that you cannot run profitably any longer any of these institutions because it just cannot recover the money. What we are now making a case for is publicly financed private medical colleges, and we need to be extremely cautious as to where this is going to be happen, and it links to this notion of district hospitals, and you have this Raichur model highlighted in the document as the model to go on, and you are really looking at an entirely different set of issues. To my mind, the central issue is therefore not an absolute challenge of increase in numbers. That challenge is there. The central challenge is how to attract and retain skilled workers in the public health services. If you saw the earlier chart, you are at a ratio of 1 per 10,000 in rural areas to 1 per 1,000 or 800 in urban areas. So the real challenge is not in an absolute increase in numbers, though some increase in numbers will become required, but it is actually a question of how we are going to manage the entire redistribution of this to the rural areas. And that, I think, as the centrality of the debate gets completely missed. The NRHM in its own way tried this with 4 different steps. The setting of the public health standards and norms on service providers availability, the improved availability to contractual appointments, the building of in-service training programs, and some expansion. You could see that this particular expansion that took place in numbers is something like 1 lakh, now the figures, this is slightly dated, is about 1,40,000 contractual skilled service providers were added, of which about 60,000 are basically on the nursing cadre. Indeed, all the service delivery improvements which you saw in the last 5 years is perhaps attributable to just this one figure. All the rest, if we know it internally, has a very marginal role on this. But again, we should note that in this discourse of the 12th plan, the commitment to increase the public health workforce is extremely weak, if at all there. There are implicit expectations that market forces will drive them to rural areas once there are lots of numbers. It goes back to the Chicago School's understanding of the medical profession as being something that interferes with market forces, and if you generate lots of numbers, they would be pushed by market forces. And the correct demand for shifting from contractual to, so there is a correct demand for shifting from contractual to regular employees, but without a matching commitment of the central government to take a share of the burden. Because today regular employees are part of the state share, and therefore what you are asking is for the states to take on the entire burden of increased workforce without the central commitment to it. And there is also, and the most disturbing element is an ideological position that runs right through these documents, where ideological against salaried employees as inherently bound to fail and inherently poor quality, and a complete spin on purchasing care through multiple mechanism and competition as the big hopes and alternatives to the provision of quality of care, and a liberal misinterpretation of international experience, Thai, Mexico, everywhere a notion that at some point you are purchasing healthcare means moving again from salaries, where if you actually look at Thailand, salaries are paid and they are reasonably fixed and stable, though you do have financial incentives, which is a different thing altogether. Okay. Now, I also want to make another point. Though the NRHM increased something like the baseline, over the baseline of 50% increase in HR, As a proportion of total NRHM spend, the spend that went into human resources was abysmally low. It's about 10% of the total went to salaries. So this general decline that the NRHM lends into an employment program providing nurses and doctors is just not true. And if you look within this, I've put it in bold, some of those like Bihar, Chhattisgarh, for example, the total proportion of NRHM budget that goes to human resources is about 2.7%. Fiddlesticks, I mean, the peanuts. It's really, at some point, you can see that this whole thing you have again. So the overall increase that the NRHM, as part of central shares increase in the salary budget, is minuscule. So at some point, the case should have been made by all these worthies who were in the consultation to actually invest more in public health workforce and in salaried workforce at that. And that is something that remains missing in these documents. But coming to the issue of attracting and retaining health professionals in area, one of the things that the NRHM achieved is not an actual change in policy, but a change in the way of perceiving the problem. So these which were at the beginning of the 11th plan raised as rhetorical questions are now seen as remediable through a number of actions. Now here it's interesting to note that we have generated a lot of experience and we have some clues about what works and what does not. Things like compulsory rural postings generally don't work. They haven't worked. They do work, however, in niche situations. Does work in Assam and Meghalaya to some reason. Rural service as pre-qualification for PG admission works, but it's a very poor quality of some students sent over there just trying to manage to study for their exams while they are disposing of the outpatients. It's a very different issue. And then reservation of seats, that seems to be moderately effective. Contractual appointments, direct recruitments, simplifying recruitments, campus recruitments have made a difference, fair transfer policies, and then this whole particular emphasis on financial incentives. Now, there is one very interesting thing about financial incentives. There's sort of overwhelming evidence from all over the world that they don't work. That's the very counterintuitive point. But that's not quite true. If you put enough in it, if it is 2 to 3 times, if Thailand, for example, a rural person will get 50,000 baht compared to getting 20,000 if you are working in Bangkok. That sort of difference does start making a difference. But for all that, and I think you'll see it in a number of presentations, we know that. But still at some point it becomes extremely required, and we are looking forward to a very, very planned effort in Chhattisgarh that is going on to really look at incentives as driving it. Mind you, our own understanding is that it has a limited role, but whatever it is, as starting to address the problem, it becomes a major important step forward. Contracting, or this word contracting in, out is always very confusing. What we used to say contracting out, HLAG calls now contracting in. But whatever, at some point they have not really worked except in niche options where, like the Karuna Trust and in Meghalaya, where NGOs have been able to sort of mobilize and maintain human resource in a particular way by providing a positive practice environment. Very marginal. Alternate service providers has been tried to some extent and have had some role. The rural medical assistant has really filled up a major number of PHC gaps in Chhattisgarh, and in Assam they have actually got it right. As compared to the earlier situation, it's really beginning to actually work, because the errors that were made in Chhattisgarh were learnt from in a rather conscious way and corrected into this. And this is now proposed to be upscaled in the bachelor's in rural medical course. And therefore, some of the things that do seem to work world over is actually these new professional boundaries that are created, the new courses, the role of family medicines, for example, to close specialist gaps, and the multi-skilling issues. But also, there seems to be sort of 4 conditions that seem to work best. Locality-based selection and training, new professional boundaries, conditional licensing, and even I would add the language of education. If you put it in the state language, your chances of people remaining there are much higher. And therefore, we do tend to know, but it's sad to say, despite presenting evidence by the by the heaps to these bodies in the working group, making it part of the working group, neither in the HLEG or in the UHC, the 12th plan report, do we find sufficient basis on this. Gaps in competence are another challenge. There is also, we need to start looking at the dimension in terms of universal health care, the ethics gaps, the problems of the private sector and the problems of the public sector. They are very different and distinct problems despite the overlaps, and we need to attend to them. And we also need to look at the ASHA and what she means as in terms of human resource improvement in this. I think we need to note that over here, there is a recommendation that the high-level expert group makes that is not really picked up for right reasons and wrong reasons, but eventually there is something that we need to work about. A few last words on the role of the community health worker as human resource. We note that in some of the most successful examples of relevance to us, in Thailand, in South Africa, in Thailand, in Brazil, you have had major programs built around well-positioned, staffed community health worker programs. And this notion of community level care with more skills and regular payments is not necessarily a problem, but a transition that we need to make after 10 to 7 years of working on the program in one way, and we need to be upgrading. Brazil did it very systematically. They replaced over time a much more qualified and much more stable worker with a voluntary immediate mobilizational worker called the agency, which they cut back as the new worker. So to make that many nurses available will be quite impossible. But today in Chhattisgarh, more than about 500 Mithanins have got themselves into nurse training schools and are coming out as ANMs and being appointed. This year they'll be appointed back into villages that were very underserviced and had no nurse in it before. So these sort of transitions, it provides a huge opportunity to create and address this problem of redistribution. These were the big issues that we really missed. So in conclusion, I have just 5 points to make. Numerical gaps are important but not the central challenge. There needs to be caution on exaggerated projections of need and publicly financed private professional education options. Second, the distribution and appropriate skill mix is central to the challenge, and unfortunately our coming plan document misses the bus on this completely. Third, building up a salaried public health workforce while enforcing performance is a central challenge. This whole dialogue, discourse about the purchaser-provider split and this misconstrued emphasis on mechanisms of payment as a solution, which implicitly and explicitly in the July draft of the 12th plan said that salaried workers is per se the heart of the problem, is a misleading discourse, and alternative solutions based on trust between health teams and communities are possible and available but deliberately missed. But at some point of time, when a patient comes to a doctor, he should be assured that there is really no other interest in that interaction except of his health, not that he is going to get a higher repayment or a lower repayment, and you need to build an enabling environment of trust around it. Maintenance of skills and ethics needs to move up front, and the long-term strategy on community level care is important. Thank you.
Thank you, Sundararaman, for nicely painting an extensive background and for the much needed critical questions that you raised.